Hello, this is Charles Epstein, host of the Catalyst Podcast. Today I'm joined by Melissa Sienna, Executive Director of MDFT International, Multidimensional Family Therapy, and also by Sandra Arguelles, National Trainer also with MDFT International. MDFT transforms lives through family-centered treatment for youth struggling with mental health and other challenges, including substance misuse, mental health, crime and delinquency, antisocial and aggressive behaviors, school and family problems, and emotional difficulties. MDFT has more than 30 years of rigorous research that proves its efficacy, and the widespread adoption of MDFT demonstrates its feasibility. Today, clinicians implement and sustain MDFT programs in over 150 public and private settings throughout the US and Europe. Melissa, Sandra, welcome.
Thank you for having us.
I should mention that you are joining us from your respective locations in the great state of Connecticut. Thank you both for taking the time. Melissa, is there anything in my intro in describing your organization you want to revise, change, add to? Now's your chance.
Okay, well, I'd like to add a couple of things. You referenced MDFT as one of the programs of MDFT International, and that's certainly where the organization started, with sort of developing and disseminating MDFT. And since then, there have been other models and interventions that have been developed by the team here. One of them we're going to talk about today, MDFT for opioid use disorders, and there are others. There's that's an adaptation of MDFT. There's also multidimensional family recovery, which is more of a non-clinical intervention designed to engage caregivers, usually, into treatment services in the community, and some new programs as well that we're always sort of designing and testing: multidimensional family therapy and recovery as a treatment program for caregivers, being tested right now with caregivers connected to child welfare. So there's a family or portfolio of services that MDFT develops and disseminates, and you can find more about those on our website.
Excellent. Well, thank you very much for setting the stage. So what I first want to ask, a little bit back up for a second, about your backgrounds, how you came to this work. Sandra?
Sure. So early in my career, I worked with adolescents and families who were struggling with so many overlapping issues. And I did that in an outpatient setting. And I had high caseload, and I had families who I felt like I just wasn't spending enough time with, or I felt, like there's got to be a better way, And I had a friend of mine who told me this agency he worked for was hiring for MDFT. There was a therapist position that was open, and I said, why not? Let me give this a try. It seemed to align very well with what I already believed in. My background was in marriage and family therapy, and because MDFT is the core of the work we do is family work, it aligns very nicely. I started as a therapist. I moved into a supervisory role. And for the last several years, I've been a trainer. So I've been involved with MDFT for the last 12 years. Time flies when you're having a great time. And this work is it's been really great. So now I get to see the other side, where I'm not only seeing families change, but I'm also seeing therapists change and evolve and just get better at the work that they're doing.
Yeah, by the way, why not would make a terrific bumper sticker. Also a refrigerator magnet, just saying.
Right.
Anyway, Melissa, how did you come to this work?
I had a very different track. I actually started out working in this field on the cannabis youth treatment study, which Chestnut Health Systems was the national coordinating center for. MDFT was one of the interventions being tested in that study, along with a variety of others, ACRA, CBT, et cetera. And from there, I started kind of learning more about what are evidence-based practices. I was on the research side for a while. And then in Connecticut, the Connecticut Department of Children and Families started getting really interested in implementing evidence-based practices. And, we already had a connection with the folks over there. So I was at the University of Connecticut, and they reached out to us because we knew a lot about the EBPs that were tested.
Am I supposed to give you a congratulations on the girls basketball team?
Oh, yeah, thank you.
Okay.
Yes, national champions.
Okay, didn't want to forget.
Yeah, please don't. Yeah, we're a big basketball state. the basketball center of the
Yes,
country. I
well,
know that is
again,
argument.
yes, pardon the interruption, but I knew if I didn't catch that when we got too far downstream, I never would mention, and I'd live to regret it.
Thank you. Thank you. Yes. So, we had this relationship already with the Department of Children and Families, and they administer the youth treatment programs in Connecticut that are publicly funded. And so we started to partner on implementing. And so that's how I switched sort of from the research side to the translational side, if you will. So the implementation side. And MDFT is one of the early models in Connecticut. I think it was the first or second model that the state implemented. And so I just got introduced to MDFT very early. The SCOIT study was like 7 years ago. So MDFT, that's when my relationship kind of started. And then I started helping the state implement EVPs, including MDFT and a variety of adaptations like the one we're going to talk about today.
I see. And you were fairly recently named executive director, correct?
Very recently, March 1st.
Oh.
Yeah. So, so I sometimes still forget where I am. I'll say we, and I'm referring to the state side when it's, yeah. So forgive those errors I might still make.
Well, so double congratulations. Connecticut and now this. All right. We're on a winning streak.
Yeah.
No, thanks, guys. I appreciate that. As you mentioned, Melissa, we want to primarily discuss the MDFT for OUD program. So I'd like for you to tell our listeners about the gaps in care that was created to address, and then we can unpack it a little bit more. But, let's begin there.
Sure. Kind of like why the state went down this road. It's interesting because so the state was doing this. It's, as far as I know, the first program of its type in the country. The state was, we were going out to a variety of listening forums and places where families were talking about the treatment system or their challenges in accessing the treatment system. And we were continually hearing about a lack of service or awareness of services for young people who have severe substance use disorders or opioid use. There in Connecticut, withdrawal management is very limited. Residential treatment at the time was very limited. Now, publicly funded residential treatment doesn't exist in Connecticut just because of financial crises and things like that. At the time, we were hearing a lot about families who are saying that they have young people who are using opioids, and there was really no programs for them to turn to that. And in talking with our providers at the time in Connecticut, providers were hesitant because of the risk of overdose. It sounded like they didn't feel equipped and comfortable working with that population. And so we very quickly, even though we weren't seeing in our data, by the way, a huge rise in youth opioid overdose, we were paying attention to the national data. And the national data were telling us since 2019, there's a huge spike in overdose deaths related to opioids among younger and younger people. And we were seeing this sort of trend kind of drift to the left where young people are being more and more involved and dying. And we thought, even if we don't see it now, it's only a matter of time if we don't do something really fast. So with all of that information, we went to MDFT International and asked if they would be interested in helping us develop a model for adolescents, older adolescents and young adults, critical age period for opioid use, really high rates of use among young adults. We were worried about our adolescents. And we chose an EVP because we also knew there was a workforce gap, a knowledge gap. When we have our adolescent treatment providers saying, hold on, we don't want to treat young people with a specific substance use, that signals to us they don't feel equipped. They don't feel like they have the knowledge and understanding of the drugs, how to treat them, manage them, keep them safe and alive.
Right.
So we knew, we knew we needed to give them a lot of training, coaching, education, support, and it had to be an EVP because that's the value of evidence-based practices. So we outreached to MDFT International and they said, great. And we said, we really know we need recovery support with this too, because we don't think that just regular care and then thanks very much is going to work very well. We were really interested in a public health approach. So we reached out to Chestnut Health Systems and Laura Pissetti over there and asked if she'd be interested in working with MDFT to integrate her or their recovery management support curriculum into this new model. And they said yes. And also, this is, to my knowledge, the first of its kind where two model developers came together to address an issue and develop a joint protocol. So it was super exciting for us on the state side to have folks who were willing to partner, have multiple EVPs, and bring the value of both together. I know that at the time, the federal government, we got a grant to do this work, to develop it and do just sort of an initial program evaluation. They were also excited. They were saying it was the first that they'd ever heard of this kind of collaboration. So it was really an innovative model in so many ways.
Excellent, excellent. Sandra, let me put this to you. Just want to get into the weeds a little bit. How does the program work? What makes it different? Well, let's begin there. I have several follow-up questions. So if you could, just in broad strokes, how it works.
Sure. So MDFT standard care was modified, right? So we did a bit of modifications so that we can work with the OUD population. And so the differences are very specific that we put in. So it's an increased number of sessions. So typical MDFT, we're doing 2 to 3 sessions per week. And it's more with the idea of what's needed, right? What does the family need? And this is what we're going to do. We're very intentional in terms of what's happening now in the present moment and what's needed to help them. And so that range is about, 2 to 3 sessions per week. And so we increase our number of sessions per week with the OUD population. So there's much more frequent contact, combining that with both daily phone check-ins with both the parent and the youth. We increased the duration of treatment. So our standard care is about 4 to 6 months, averaging about 5 months here in Connecticut specifically. But then,
by the way, let me just interject. Is there any requirement as far as the modality of those engagements? Does it have to be in person? Can it be a teleconferencing
right,
platform?
yes. So the only requirement is that we have families that need it, right? So we are a community-based program, but we do have the flexibility to have sessions in the office, sessions in the home. We go out to the families. They don't have to come to us. So that's one of the biggest components of the program, is that with outpatient therapy, we're kind of sitting in the office waiting for them to come, and they don't always come. And this allows us to go out into their home, go out into the communities and meet with them and look for them if needed. So that's a big significant difference there.
Yeah, lowering those barriers is so key to all this stuff to engage. Any other thoughts to add to that, Melissa?
Just to add to make sure people understand how flexible the model is, Sandra and I were chatting beforehand. MDFT will partner with community organizations and services that the family and the youth are connected to. So visits can happen at probation offices, at schools, at wherever in the community the young people are. Again, to facilitate the access to the service. So it's such an important feature of the program, is that flexibility. And no, we don't prescribe that you need to do X number of individual sessions and X number of family. It is really individualized. So I think one of the myths of evidence-based practices is that it's cookbook care, right? You're going to follow step A, B, C, then mix it all up, and you've baked your cake. But the reality is that it's really, really flexible and individualized. We do promote that all the types of therapy contacts have to happen. So working with the youth individually, working with the parents separately, and working with the youth and family together, all that has to happen. But how it happens and what kind of proportion is really individualized.
Yeah, that seems to be something of a common thread. All the programs we talk about on this podcast that are involved or initiated by Lighthouse Chestnut, is this whole concept, which is to say, going where people are, being flexible, tailoring interventions, because just like everybody has a different learning style, there are some cultural issues, we all know this. So it is obviously a greater recognition that informs almost all the programs we've been discussing. So it's kind of fascinating. Melissa, tell us about the Connecticut Demonstration Project, a pilot study involving participants aged 15 to 19 diagnosed with OUD. If you would, tell us about the methodology and your findings.
Yeah, sure. So I want to clarify that it wasn't so much a study as a program evaluation. So remember at the beginning of the podcast, I was talking about we came together to develop a new approach, a new model. And so this first demonstration project was really kind of a feasibility and implementation study. So we wanted to understand, A, can we take these three components, multidimensional family recovery, this more intensive and intentional engagement package, with multidimensional family therapy as the hub therapeutic intervention. We added, as Sandra mentioned, a variety of very specific interventions to support young people and their families where there's opioid use. And then we added RMS. So we've got three things happening. So the first thing we wanted to know is, can these things come together and feel like a cohesive, seamless, and approach? Can we do it? Can we develop a joint program manual across multiple EVPs? So just it is can it happen? And then can we implement it? What does it take to lift up? Does it take anything special amongst our providers? For example, special qualifications or skills or et cetera. And then do clients benefit in the way we expect? So when we think about the demonstration, the data, it's really programmatic data. We didn't have a comparison. We looked at changes from intake to discharge among the youth that entered the program and had what we could identify as a diagnosable opioid use disorder, because we had a lot of youth who came in who had a variety of substance use problems and some significant problems, but we couldn't necessarily say they had opioid use disorder. So in that study, I'm air quoting it, in that demonstration or evaluation, we had in the first demonstration, we continue to collect data, but I'll talk about the first one. We had 24 young people we could systematically say, yes, they had an opioid use disorder. And from the data that we collect, so we use the GAIN, Global Appraisal of Individual Needs at Intake and Discharge. And then there are a variety of other assessments that MDFT and the providers are required to do by their accreditation and licensing. So from all that information, we were able to sort of triangulate and say, yes, these young people definitely had an opioid use disorder. Well, how did they do? And we were able to find that among that small sample, really promising effect. So most of them, somewhere between, almost 9 out of 10, 88% or something, really reduced their use of opioids and other hard drugs like benzodiazepines and methamphetamine and things like that. They had really great improvements in mental health and engagement with school, et cetera. Very few, I think we only had 2 young people, which was like 8% of our sample, needed higher levels of care. So we were able to maintain these youth in community settings at home. That's a really important finding, because when we were developing this model, we consulted with Mark Fishman down in Baltimore, Mountain Manor, who's considered one of the experts in the field on adolescent opioid use. He's one of the few who really dedicates his time to researching and treating this population. And he was saying, really, for you to be successful, you want to be enrolling young people who are stepping down from or continuing their care post-residential treatment. But as I mentioned in the beginning of the podcast, we had very little access to residential treatment in Connecticut. It was not going to be an option for us. We needed a community-based solution. So the fact that we were able to keep these kids in community, they were able to reduce their substance use, really reduce their risk of overdose potential and death, and can stay in care. We really engaged these young people and got them really good care, was really promising for us. And so my response to you, Charles, is we'd love to continue to do this work, both in Connecticut and elsewhere, to continue to test and study the effects using more robust, designs. But during this particular demonstration, the program evaluation really had some very promising results that we're happy about.
Yeah, you talk about the need to sort of almost like inject yourself, having a community-based approach. And my understanding of those kind of probably the important thing, or one of the most important things, is communication, getting out there. This is a new model. So how did you do that? How did you get the stakeholders to wrap their heads around this and get behind it and actually implement this?
So in Connecticut, I think because we were being informed by what the communities were saying and our providers were saying, not only did we say to providers, yes, we want you to do this model and treat kids with opioid use disorder, we said, no, we're going to give you a lot of training, consultation, support, education. It's this continuous learning process, and Sandra can speak to it in far greater and more eloquent detail than I could. We integrated interventions into that protocol that really supported families with like overdose prevention plans. We provided naloxone directly and educated them about that. There's a lot of family education about opioids. There's an opioid assessment, withdrawal assessment that happened. So there was a lot of support that the providers were getting in terms of education and coaching and consultation from the MDFT national trainers. And the families were being supported, so they were empowered they were educated and empowered to also support the young person to prevent opioid overdose events and to respond to them if they happened. So I think, everyone felt supported and comfortable taking on the work. And then we just asked providers who's willing. We're hearing that there's a need and there's hesitation on your part to serve this population. Not that you don't want to, but you're concerned about, right? Like not being well equipped. And we came to the table with the equipment and the training for them to implement it and do the job. So I think that, and we took the time and listened, and we took like a year and a half working with providers and planning the model, the evidence-based practice developers, to make sure that those values, those concerns were addressed and it's influenced by the end result. So I think all of that mattered, taking the time.
Yeah, I'd just like to get Sandra, your perspective as, national trainer in your role to what Melissa is talking about, to what you found initial barriers that needed to be overcome, just sort of a field level perspective on the rollout.
So barriers that we needed to overcome were basically being able to be flexible to involve other families that are not just the parent focused. So when we say family, we're involving probation officers and maybe school officials and anyone who's really important and key to that youth or that young person's life. And we want to make sure that the therapists who are working with these families, especially because, the work that we're doing, we're saving lives. This is a really critical thing. We're watching young people overdose, and we're watching, and we definitely need to do a bit more. So the therapists that we're working with are going into these sessions, are going to work into the communities, working with these families, much more better prepared than standard care, right? So Melissa talked about the training process, where we go through a certification process, we go through a recertification process, we're involving not just a therapist, but as supervisors, and we're seeing their work in real time. So, we're doing live supervision, we're watching their videos, we're really hands-on in terms of the coaching process and the learning process, so that we can assure that the work that's happening in the community is the work that's going to be the most effective. So it's really intense and robust. It's not for everyone, but it definitely makes a significant difference in what we're doing.
Yeah, for sure. Melissa, you started to talk a little bit about funding program. So I'm kind of curious. It's currently in 6 sites across the state, correct?
Correct.
Any plans expanding it over the coming year, perhaps even beyond Connecticut?
Yeah, so right now, Connecticut Department of Children and Families submitted a recommendation to their opioid settlement advisory committee to transition the remaining standard MDFT teams in the state to HYPE for OUD. I'm sorry, MDFT for OUD. In Connecticut, that's called HYPE recovery. So there's currently that's under review, and we should know more in the next couple of months about that particular funding mechanism. And the idea is no wrong door, that every MDFT clinician in the state, should a young person with opioid use kind of come into care, that they don't have to transition that person to an MDFT for OUD team that exists somewhere else in their region, they have the capacity to manage that. So that it would give us much more capacity. And then, of course, we're always looking for partners anywhere in the country. As Sandra mentioned, what we were able to do with the demonstration project, one of the deliverables for that was to develop the treatment protocols, the intervention guides, the training guides, all of the training consultation support model through that grant process was developed. So it is ready for and scalable. So it's ready for dissemination to partners all over the country or the world who are interested in seeing if this could benefit them.
Yeah, well, you guys are doing amazing work. I really do appreciate you coming on and discussing MDFT in this program with me and our listeners today.
Great. Well, thanks for having us. We'd love to come back and talk with you about lots of MDFT programs and services. So it's been
I'd love to have you back because, the work you do is so fluid. It's evidence-based, which obviously implies you're gathering more and more information, more and more data, more and more insight. So 6 months of this conversation may take a different turn, and you're obviously doing other programs. So absolutely.
Great.
This is my formal invitation to have you guys back in 6 months.
Well, we're going to take you up on it in advance.
Excellent. I really do appreciate it. Thanks so much. Today I spoke with Melissa Sienna, Executive Director of MDFT International, and with Sandra Arguelles, National Trainer, also with MDFT. They joined me today from their respective offices in the great state of Connecticut. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.